Hi, everyone. Welcome to this recording of JACC Asia Pulse. My name is Dr. Mayank Dalakoti. I'm a cardiologist from Singapore and Cambridge in the United Kingdom. And I'm joined by my colleagues, Dr. Kang from Korea, Dr. Sheng from the US, and Dr. Ahn from Korea as well. Today's session is focused on the global burden of disease as a means to assess burden of disease around the world, but also to focus on how this pertains to Asian populations, both within and outside of Asia. So we'll start first with a quick overview of what the global burden of disease is about. So this is essentially a study which is one of the best resources we currently have for understanding how health is evolving and how we can improve it globally. So the global burden of disease, or the GBD for short, is led by the Institute for Health Metrics and Evaluation, or the IHME, at the University of Washington. It provides more than 607 billion highly standardized estimates that quantify health outcomes and system performances around the world. This covers 463 diseases, injuries, and risk factors. It spans 204 countries and territories. It also gives detailed subnational estimates. Over 17,000 researchers from 167 countries are involved in the process to vet the data sources and refine how these estimates are performed. And so we've been receiving data from 1990, and this has just led to the most recent report, which has included data until 2023. So the next portion of today's discussion is going to focus on the recent special report on the global burden of disease until 2023, specifically cardiovascular disease, published in the Journal of the American College of Cardiology. And this report focused on the alarming rise and shifting geography of heart disease worldwide. A few key takeaways from me before I will then hand over to my colleagues to discuss certain matters about populations within and outside of Asia. So the first key point for me is on the burden of disease, specifically cardiovascular disease around the world. We know that cardiovascular disease accounts for 1 in 3 deaths worldwide. This is quite a staggering number. The number of cardiovascular deaths has risen from 13 million or so in 1990 to more than 19 million in 2023. Now, much of this reflects population growth and aging, but the report also highlights that there are clear geographic inequalities, with the greatest and fastest rising burden stretching across this belt-like region between Asia and Africa. And these are some of the regions that are least equipped to bear the effects of cardiovascular disease. In 2023 alone, there were 437 million disability-adjusted life years, or DALYs, lost due to cardiovascular disease. And this number has risen 1.4 times since 1990. The leading causes of cardiovascular-related death are ischemic heart disease, intracerebral hemorrhage, ischemic stroke, and hypertensive heart disease. Now, the second key point that I would like to make here is on the key risk factors, which in many sense of the word are causing cardiovascular disease. And so 80% of all cardiovascular disease are attributable to modifiable risk factors. The major risk factors, of course, metabolic, behavioral, and environmental. The metabolic drivers in particular are of concern. We know that high blood pressure, obesity, as reflected by a high BMI and global data, and high fasting glucose, these have risen sharply in recent years. We've also seen how this has corresponded with a surge in diabetes and metabolic diseases worldwide. Behavioral risk factors, such as poor diet, the use of tobacco, alcohol, and physical inactivity, remain major contributors. And finally, environmental and occupational exposures, such as air pollution and non-optimal temperatures, also continue to cause millions of preventable deaths. So all in all, this report throws down the gauntlet for local, regional, and international efforts to address the rising tide of cardiovascular disease. I shall now hand over the time to Dr. Ahn to speak about some of her key reflections from this report.
Thank you, Mayank, for the introduction. Hi, my name is Hyun Jin, and I'm a cardiologist from Seoul, Korea. I would like to talk briefly about the characteristics of cardiovascular disease in Asia. So from 1990 to 2019, Asia has been the only region in the world where cardiovascular disease mortality has increased, whereas other regions such as Africa, America, Europe have all seen steady declines. This rising trend highlights an urgent need for stronger interventions targeting cardiovascular risk factors. It's also very important to remember that Asia is a very large and diverse region, including many countries, from high-income nations to developing ones. Um, this makes Asia very heterogeneous with substantial differences in cardiometabolic features, culture, health literacy, socioeconomic status, and also healthcare systems. I would like to highlight this heterogeneity within Asia, especially cardiometabolic risk factors and socioeconomic status, as understanding these differences is essential for creating more effective approaches to cardiovascular prevention. Uh, Next, for cardiovascular risk factors, there are, of course, many aspects that need to be controlled, such as high blood pressure, high fasting blood glucose, smoking, air pollution, and so on. Of these, hypertension is one of the most important risk factors, and it's highly prevalent across Asia. However, I would like to highlight that the prevalence of hypertension varies greatly among Asian countries. The highest age standardized prevention was observed in Yemen at around 31%, while the lowest was in South Korea at about 11%. In general, countries in Southern and Central Asia tend to have higher hypertension prevalence than those in Eastern or Southeastern Asia. And this difference in blood pressure levels is also reflected in the burden of cardiovascular disease. On the right figure, you can see that in 2023, the age standardized cardiovascular DALYs attributed to high systolic blood pressure were high in Central Asia, but low in high-income Asia-Pacific regions. These findings show that even within Asia, there are large variation in both hypertension prevalence and cardiovascular disease burden. Next, Asia comprises a wide range of countries with very different socioeconomic statuses, and each group face unique cardiovascular challenges. For example, low and middle income countries such as India, Pakistan, and Bangladesh tend to have lower overall cardiovascular disease incidence and mortality rates, but they experience a larger proportion of premature deaths, meaning deaths before age 70. This is often due to limited awareness, lower health literacy, and lack of population-wide prevention campaigns. On the other hand, high-income countries like Japan, South Korea, and Singapore have lower mortality rates, but face increasing numbers of patients with cardiovascular risk factors. Meanwhile, upper middle income countries such as China and Kazakhstan are in a transition stage. So they're dealing with both rising cardiovascular disease burden and also ongoing communicable diseases. Since cardiovascular disease burden is inversely related to income and education, I think that greater focus on prevention is urgently needed in low and middle income countries, where the rise in cardiovascular disease is projected to be the most dramatic. With that, I would like to hand over the talk to Dr. Sheng.
Hi, my name is Qicong. I'm a second-year internal medicine resident at UCLA, part of the JACC Asia Pulse team. The global burden of disease paper is a fascinating read for me. This makes me think of how we provide cardiovascular care for Asian populations outside of Asia, which is a very large population, especially in Europe and North America. Take Asian in the US, for example, there are over 20 million Asian Americans. And when we use the term Asian American, it is really a very heterogeneous term. It includes people from all different parts of Asia with very different cardiovascular risk profiles, as Hyun Jin highlighted. And as we can see in this figure as well, with the global CVD DALYs. Also, Asian American might mean someone of Asian ancestry who's born and raised in US, or someone who spent their majority of lives in Asia and came to the US as new immigrants. and same applies to Europe. Because of this, their diet habits and environmental exposure can be so different, resulting in very different cardiovascular risks too. Next, I would like to highlight this graph, which is the risk of stroke, which is elevated in the Asian populations, in Asian countries, but relatively lower in the Western world. Among the stroke, Asian populations are especially prone for intracerebral hemorrhage, partially due to a genetic component, but also partially related to the high sodium intake in the traditional Asian diets and related hypertension. Although the overall risk for stroke is lower in the US and Europe, the risk for specific Asian American or Asian European is not lower. And this is something that clinician should pay attention to. Next, I want to highlight a point regarding BMI. Asian populations develop metabolic complications, including diabetes and hypertension, at a lower BMI than Caucasian and other populations, partially due to a higher visceral fat tissue content among Asians. The guidelines in Asia actually have lower BMI cutoffs. For example, the US, UK guidelines define overweight as BMI 25 or above, and obesity as BMI 30 or above. While in Korean guidelines, overweight is actually BMI 23 or above, and obesity is BMI 25 or above. And in Chinese guideline, it is 24 for overweight and 28 for obesity. And we can see similar patterns in India, Malaysia, Singapore, and all the other Asian countries as well. This is important because a Korean American with a BMI of 25 might have significantly higher metabolic risks compared to a non-Asian patient in the US. But the screening in the primary care office a lot of times won't get triggered to initiate weight intervention for this particular person because of the Western guidelines. It really highlights the importance of knowing who the patient is beyond the numbers in their EMR charts and their race and ethnicity group, for us to truly provide equitable and effective care in this increasingly globalized world. Now I will hand over to Dr. Khan.
First of all, my name is Jeehoon Kang, and I'm working as the JACC Asia Pulse Specialty Contents Editor. And you just had a brief talk from each of our very nice members. And this, as Dr. Mayank has just told you, this is an introduction of the GBD paper that was presented in JACC about a month ago. So recently we're talking about how diverse the world is, and especially how diverse this is in Asia. So from this slide, we can see that there is a very diverse population within Asia, and also a very large population, a very diverse large population which are present outside of Asia. And when we collect these population, we can see that the Asian population consists of about more than 50% of the world population. So overall, the population that we have in Asia is very important, and we should have very nice care for this patient to increase the overall burden of cardiovascular disease worldwide. So we talked about risk factors. Hyun Jin just mentioned about hypertension. Dr. Shen mentioned about the outcome of risk factors, which is stroke. And among these various risk factors, even within Asia, we have a very nicely consensus of which are risk factors, but the profile of which is important, which has a much higher impact among these risk factors, is very different among the Asian population. For instance, in East Asia, a high BMI is most important. In other countries, a fasting glucose is more important. And in some countries, even tobacco smoking is the most important risk factor, modifiable risk factor that should be controlled. This means that we should have a individualized approach to each country to efficiently reduce the global burden of cardiovascular disease in each country within Asia. So as a conclusion of today's speech, this goes back to the slide that Dr. Mayank showed us in the first slide. So we can see that the cardiovascular disease remains as the leading cause of disease worldwide, and especially in Asia. And within Asia, we could see that there's a large variation of the CVD burden, the risk factors that are, sorry to say, inadequately controlled. So we should have a collaboration of effective health systems and public health strategies to control this cardiovascular disease, not only within Asia, but also worldwide. But as we are a population within Asia, having a nice collaboration within Asia might be the first step that we can nicely treat, nicely control cardiovascular disease within our population. So this is the final slide that we prepared right now. And I would like to thank all of our team members summarizing this paper. And for the readers, I would like to encourage the readers to download this paper, have a look at it. And I hope that our short summarization of this paper gives everybody help in treating our patients and treating the patients in the clinic. I hope that we will have another session discussing about the cardiovascular disease within Asia. Thank you.